This is a research proposal assessing structural stigma related to evidence-based programs from the Title IV-E Clearinghouse on family preservation services, brought to you by Brent Kirby for Liberty University. This topic in particular is of interest to me. I was formerly a family preservation director in the state of Indiana, being given a team of 3 and seeing it grow to over 50 with 6 offices statewide in Indiana. I currently work as a family preservation therapist and wonder how much stigma is impacting our families, especially systemically. My passion overall is to see children have a safe and loving home. This is my calling as a professional and why I'm pursuing a doctorate. Some key terms to be aware of are child welfare, which is a government system to watch over children's safety and well-being. Evidence-based programs, or EBPs, are programs that have research that point to their effectiveness. In child welfare, these are usually listed on online clearinghouses. Family Preservation Services, or FPS, is a preventative treatment service designed to keep families together who've had substantiated child abuse or neglect of their children. Indiana Department of Child Services is a state department with the goal to keep children safe in a nurturing family, also known as Indiana DCS, or DCS for short. Successful, unsuccessful FPS case, just for awareness, when an FPS case closes that with children that are in the home still, that's considered successful. Title IV-E Clearinghouse is a federal website that rates the research evidence of a treatment model or a treatment theory from a 1 to a 4, with a 4 being well supported. And the word underserved for population, California considers these populations being 75% worse off than others, and that can include income, education, health, racial representation, and in some places, even poor environment. For our literature review, we begin with statistics. 2,000 children on average die each year in the United States due to child abuse and neglect. Sankaran and Church report that this is likely 2 to 3 times underreported. Karmati found that 400,000 children are in foster care currently in the United States. 2.8 children out of 1,000 enter foster care yearly. A child's mortality rate over their lifespan increases 2 to 3 times once removed from their family. And as of 2025, Indiana alone, according to the Children's Bureau, had 100,000 cases of substantiated child abuse and neglect. Some key points on our timeline when it comes to child welfare are the U.S. government has passed a series of congressional acts, and these have impacted what treatment looks like and what child welfare looks like. For instance, in 2010, the Child Abuse Prevention and Treatment Act was passed, moving child welfare from being completely punitive to attempting to focus on a family's strengths and the child's strengths. Later, in 2018, they didn't feel like that fully took effect, so they passed the Family First Prevention Services Act, or FFPSA. This was a move from child welfare from being reactionary or removing a child to preventative or preservational. Thus, we see in 2020 in the state of Indiana and many other places, family preservation services being started. It doesn't have the words FPS in it in every state, but every state has a form of preservational welfare. In 2021, this was further increased by the Advancing Racial Equity and Support for Underserved Communities being passed. In 2006, the California Evidence-Based Clearinghouse was created online, or the CEBC, and that was restructured as of 2010 and 2018. In 2018, in response to the FFPSA, the Title IV-E Federal Clearinghouse was also designed, which looks at, similar to the CEBC, looks at these programs that are out there and measures their effectiveness. Now, as of 2018, it's interesting to note, state programs now only receive funding if they're using treatment programs that are listed on a clearinghouse. Systemic adaptation is evident looking at the literature. This study here by Goodwin and others is focused in on the state of Indiana and shows that the state of Indiana is adapting to the changes of these congressional acts in order to obtain funding. EBPs are implemented in this study and they're measured by their success or their unsuccess, being children still in the home, at case closure. The results here in this study were between the control group that had no EBPs and was treatment as usual, and then those who were using evidence-based programs. They found no difference in the success of a case, but they did find difference and were able to show that difference in the number of cases that had repeat maltreatment. That is, a case closes out, and then whether or not they have child welfare come back into their life or not. Also, this study by Carmody in 2024 really highlights that not only the state of Indiana, but this study looks at multiple states using a qualitative method to see between 2 or 3 states what they are doing to change in regards to the FFPSA. Their results were that they found that funding really is a complex process. It's not as easy as it seems. Evaluating EBPs is actually very difficult. They found that states aren't listening as well to actual families in care and they need to listen better. And they wondered in this study whether clearinghouses are using modalities that have been tested on underserved populations. And they found that many of them were not. And they wondered if that was potentially increasing stigma. Evidence-based programs are adapting to this research funding. Many treatment approaches and models want to have states use their model so that they receive more funding as well. So this is one by Buck and others recently. That's a parenting program that measured 14 assessments across time periods through a mixed method study. They found that their parenting program was statistically significant compared to a control group. These type of studies are prevalent in the current research because treatment models have to show their effectiveness so that they can get onto a clearinghouse. We also turn to social work and stigma research that's out there. Is stigma evident within social work? This is a study by Elric and Garg and others that highlights the stigmatic attitudes of social work students. These are bachelor's and master's level towards homelessness and the impoverished. It's a quantitative survey which found most students had a favorable attitude towards homeless and impoverished. All students, though, had a lower level of trust, interestingly enough, toward the homeless and impoverished. Master level students, maybe because they had more experience or more education, they had a significantly higher favorable score or less stigma compared to bachelor level. We have to ask, is this lower stigma associated with increased training? Another study by Tillotson and others highlights stigma bias within social work syllabi of educational programs. This one is also a quantitative inquiry using critical race theory. The results found that the authors of the textbooks listed in the syllabi were predominantly male. In the bachelor programs, though, they had more female than male authors if you break down the master's and the bachelor programs. Overall, though, the authors were predominantly white. Bachelor programs 85% and master's programs 93%. We look now into another study by Kroll, which looks at stigma in social workers themselves. This was a study between Sweden and the United States. This used a grounded qualitative method looking at social work stigma. The Swedish views of social work were that social work was respectful profession, had no stigma, and was community enhancing. The views of the social workers themselves on families, they considered some families thinking of themselves as too worthless. The U.S. views were a little different. The U.S. views of social work generally were that it was a disrespectful profession, stigmatized, and low ranked. The social workers, some of them, viewed their own families as too bad off to help. And then we look at the funding, and there are some articles on the actual funding impact on families. Zwane and others is one of those. And this study highlights the positive impact of government funding sources. It used propensity score matching to form estimations on the impact of families. They discovered that the results were that funding did overly have a positive effect in assisting families, especially impoverished families. It had a less impact upon those families that had a male as the head of household. And it did seem to have an overall impact on reducing inequality because of the funding. There is a problem, and that is there's a gap in the research on whether evidence-based programs decrease stigma within child welfare cases. This is especially true in family preservation services, where caregivers have increased potential to receive stigma due to abuse and or neglect of their children. While research does exist on stigma and how it's present in social services toward underserved families, does stigma decrease in staff who are providing evidence-based programs delivered as listed on the Title IV-E Clearinghouse? This leads us to our question and our hypothesis. Our question is, does the number of well-supported and, quote, supported Title IV-E Clearinghouse evidence-based programs that an Indiana FPS provider uses with a family decrease the structural stigma, regardless of provider race, experience, family income, location, or referral reason? Our hypothesis that's null is there will not be a statistically significant negative linear relationship between the level of structural stigma of a family receiving treatment and the number of well-supported and supported Title IV-E Clearinghouse evidence-based programs that an Indiana FPS provider uses, controlling for provider experience, race, family income, location, and referral reason. Our alternate hypothesis is thus there will be a statistically significant negative linear relationship between the level of structural stigma of a family receiving treatment and the number of well-supported and supported Title IV-E Clearinghouse evidence-based programs that an Indiana FPS provider uses, controlling for provider experience, race, family income, location, and referral reason. Our independent variable and dependent variable connection. Let's unpack that. Our independent variable is the number of high-ranked Title IV-E Clearinghouse programs. Our description is the number of well-supported and supported Title IV-E treatment programs used with a family for each family preservation service case. If you go to the Title IV-E Prevention Services Clearinghouse, this is what you'll see. On the left side of your screen, there is a place where it says Program or Service Rating. There are 5 levels that the Title IV-E Prevention Services Clearinghouse rates each theory or model that's out there. We are looking at the number 1, which is well supported or supported. If we zero in on a specific model, this is what it looks like. This specific theory would be considered well supported. We're also looking at this because it's thought that the programs are ranked higher because they have more research evidence, which points to their effectiveness. It is assumed from the literature that effective programs require organizations to train their staff more. And we look at the literature such as the master's and bachelor's literature and think master's level had potentially less stigma. Staff trained more by using high-ranked child welfare treatment programs may demonstrate less stigma toward underserved populations such as those found in family preservation services. Thus, the more effective programs in practice by an organization, the less stigma that may exist. Our dependent variable we're looking at is structural stigma. Stigma in the research is defined in many different ways, but for this case of this research proposal, we've decided to define stigma as disrepute, discrimination, or stereotype that's been labeled upon others. And that's pulling from Favelin and Kogen. Structural stigma is stigma that is perceived by those receiving services or treatment from providers and really has to do more not only with that provider, but also on a larger level, the culture of that provider. We are looking to measure this dependent variable by use of the assessment Stigma Cultures in Healthcare Scale, or SCHCS. This assessment is a 23-item 4-point Likert scale going from strongly agree to strongly disagree for each item. These items are 1 through 23, and as you can see here, this is just a few of those items. I was taken seriously, my needs were met, I was paid attention to, I had choice, etc. We're looking at this assessment, and this assessment's fairly easy. It's not reverse scored, it's all straightforward, meaning that increased scores have a higher level of structural stigma. The cumulative scores range from 23 to 92. The mean average score is used for the total scale score. For our research proposal, we're looking at multiple covariates that must be controlled for. And these fall into two different levels. Level 1 is actually the family, and level 2 is the provider staff, and these are nested. Our rationale here is by looking at the literature from Selhay and others, and Orsi and others, and who really state that stigma is very difficult to examine, so confounders must be controlled for. We're dividing these covariates into two levels. The first one is family, and underneath family, we're going to look at the tiered levels of income. We're going to look at their race. We're going to look at the location, whether it's urban, rural, or mixed. And we're going to look at the reason for referral by DCS, neglect or abuse. Now, DCS will have cases where both are combined, but they almost always will select either neglect or abuse as the primary reason for referral. Specifically with the family, we're going to be looking at the head of household that is designated by DCS, which is generally going to be the female of the home, unless the male and the female have a full marriage and they have both have full custody of the children. Level 2 here is going to be our provider staff. We're going to look at their race and also their years of experience within the child welfare field. These are going to be obtained in two ways. The family data is going to be obtained through Indiana DCS administrative records. They hold those they hold these demographics and more upon families. And then the provider staff data is going to be collected from the agency administrative level data. There are multiple theoretical foundations which are underlaying what we're doing and the approach that we're doing. The first fall under the category of the Bible. And for this sake, we are looking at the New Living Translation. We're looking at Johnson's book, and there's multiple different ways to look at psychology and Christianity. We're looking at an integrational view, which is basically taking both and saying, hey, there's theories and approaches in the Bible, there's theories and approaches in psychology. How do those look when they integrate together? Within Johnson's book and the integrational view, the idea of imago Dei is paramount. And this is pulled from Genesis chapter 1:27, where it talks about man being formed in the image of God. And from this image of God, we really start to see that all life is sacred. And if all life is sacred, then those who are in family preservation are also considered sacred. Not only the children, but also the parents, to overcome that idea of stigma, to say we are all created in God's image and we are all valuable. We zero in on children and in Psalms 127, and we see that children are like arrows in a warrior's quiver. They are a reward, or some translations might even say they are a gift. And we're looking at children as a gift. And we want to say, how do we help these children who are in family preservation have a home that is not only safe, but also full of nurturance and love? And then we look at Paul's words in Ephesians 6, chapter verse 4, and he commands or encourages parents to guide their children. The struggle here is that many parents may not know how to do that because they don't have the backing of parents who showed them love and care and guidance. And so part of our work is to come in alongside them and help them to do that through family preservation. And then last, we think about family preservation, and there likely is a component of trauma of some kind, especially with DCS coming in to a person's life. And so Psalms 147, verse 3 talks about how God wants to heal the brokenhearted. And part of our work in family preservation is coming in and healing the brokenhearted. And how do we do that best? It's by examining how to reduce that stigma that's in the family so that we can have better outcomes. And that is ultimately the hope. This leads us to our psychological foundations. We're looking at Goffman's stigma theory. And according to Smith and others here recently in 2022, they really highlighted how Goffman showed that a person's identity is destroyed by stigma. We're also looking at Corrigan's model of stigma theory. And Corrigan divided stigma into three different areas: the public stigma, the self stigma, and then the structural stigma. And we're pulling out that structural stigma and saying, how do we start to change this? And maybe evidence-based training programs would be part of that. And then we're looking at, according to Gorman and Azell, we're looking at structural competence theory. And it's this idea that from the top down, culture is made. So in the case of our research proposal, we're saying that the state level changes, and the above that, even the congressional changes have trickled down to the states, which have trickled down to the providers, trickled down to the provider staff, and into the family's home. And then we're looking at Shattuck and others, and Schroffnagel and Sheet, and we're looking at how do we implement this idea of implementation science framework, or how do we implement evidence-based programs into agencies to shift the very culture of the provider staff. This leads us to the power analysis. Literature from Moyert and others, when it comes to child welfare, they recommend that a power level for most studies be at a 0.8. This is especially important for new areas of research. We find that family preservation services, especially in the state of Indiana, is only as new as 2020. Therefore, the power level needs to be higher. They also recommend that the effect is a large effect for a study such as we are presenting. My initial approach was to use G-Power to analyze the power analysis, but I found quickly that this is not helpful and not able to be used with this type of a study due to the multiple levels. So after obtaining permission, I was able to run multiple simulations through what's called a Monte Carlo simulation through Grok AI. Grok AI on the right here in figure 1, you can see that this is the power analysis for a one-tailed two-level mixed model as we are presenting for our study. In order to achieve the recommended power of 0.8, the Monte Carlo simulations recommend 8 to 19 agencies, so we have some flexibility depending on the number of staff that that agency has. We're looking at a total of 30 providers to be used, or provider staff, and each of those staff need to have at least 8 families that they are currently treating. This is a total of 240 families. The estimated power level for a sample pool of 240 families is exactly at 0.8. The estimated effect is a regression coefficient that is around negative 0.5 or a large one. The criteria for participants really begins at the agency level. We have to look at agencies who are currently delivering Indiana FPS. That is, that they are contracted with DCS to do so and are actively doing so. These agencies need to be providing at least one evidence-based program, and that is going to be the case for family preservation anyway, because that is the standard that DCS has set for these agencies who are using family preservation services. And these agencies, we want to see them having at least 4 providers that are using family preservation services. At a provider level, we're looking at providers serving, as we said already, at least 8 families, and then using at least one evidence-based program with the families. And then for families, simply that they're receiving family preservation services. In order to recruit our participants, we're going to first go to the agencies through obtaining a list from DCS, and then either the lead researcher or DCS, depending on if that's what DCS wants, will then approach those agencies about this research proposal. From the agencies, we will obtain a list of recommended providers for this research, and then the providers will be approached by the lead researcher. Of course, through this process, as the note at the bottom says, confidentiality results will be discussed with each entity via informed consent. And then finally, the families will be approached in order to avoid potentially hampering the results of the stigma assessment. We will have who is called the family case manager for DCS, who's in charge of that family's case, be the one to recommend this research proposal to the families. Our method for this study is going to be a quantitative analysis using a quasi-experimental approach. We can't be fully experimental because these families are not completely random. This study is going to use a hierarchical multiple regression. And this is how a hierarchical map might look. In the top left, we have our covariates for the family. We're going to run those first. And then on the bottom left, we have our covariates for the provider staff. We'll run those second. And then we're going to combine all of these together and run them as well for regression coefficients to see if the programs sticks out. So ultimately, this is multiple linear regressions that we're running to control for the covariates. This is a scaffolding process of the predictor values. We're going to use SPSS, currently version 30, using what's called blocking to create these nested levels. We're going to look at the R squared to see how much change is happening. We're going to test for significance and power. And then we're going to check for direction, as we said in our hypothesis, looking to see if it's negative. So in other words, our model looks like a 2-level nested design. Level 1 is going to be that income plus referral plus family race plus family location. Level 2 is going to be the programs plus the experience plus the provider race. And then level 3 is going to be all of them combined. Our timeline for the first 2 months will begin with making sure that all researchers are up to date on their CITI training. CITI is an ethical training for researchers. Then we're going to turn to Liberty University and obtain Liberty IRB approval by completing the Participant Rights and Information Compliant form available on their website. We're going to complete an application for Child Abuse Research State Form 116, and that is found on the in.gov website. Then we're going to train the lead researcher or other researchers on the required Indiana DCS courses. There's between 8 to 10 courses that anyone who is involved in working with confidential DCS client data must complete. We're then going to reach out to the DCS Senior Research Analyst and discuss the project and set a date and time to begin. The next month, we're going to shoot for 10 agencies, with likely larger agencies chosen more so over smaller agencies to ensure saturation and to ensure that providers have enough families that they're taking care of. The maximum families per the service standard of family preservation in the state of Indiana, the maximum families that can be taken care of is 12. Obtain informed consent from the agencies. We're going to go to them and talk to them about that. We're also going to discuss with those agencies the number of evidence-based programs that they're currently using. Then we're going to select the providers, obtain informed consent from them. We're going to collect the provider level covariates. Then we will train the DCS case managers on how to present this research proposal to families. We will then select the Family Preservation Services families. We'll obtain informed consent from those families through the DCS case managers. We'll collect Family Preservation Service family covariates via the DCS records. And then we're going to text a mobile-friendly version of our structural stigma assessment to each family. And this will likely be done first by obtaining permission from the assessment creator to be able to create the form as a Google form and then text that message or text that assessment directly to the families, with the case manager being present to ensure that the family receives the text message. We will then analyze the data that's received, and then we'll publish that data. And this process here will take probably 3 months. There are a few limitations or challenges to this study. The first is this idea, this concept of social desirability. Merritt in his literature really highlights the idea, especially in child welfare. There has a tendency for families that are in child welfare to give the answer that they think will best help their case. So families may tend to be more positive in their answers, especially when they think that it may reflect well upon them, especially since they are court mandated for services. There are maybe a couple of theoretical issues. Gurung, in his article, truly talks about multiple covariates, especially in stigma studies. So there may be some that are missing. The other theoretical issue is with stigma. There are these other two areas of stigma, including personal and public stigma, that may confound or overlap with structural stigma. And then finally, there may be at least one or two methodological weaknesses. We see Reed and Dale use not a hierarchical approach, but they use a structural equation model, which is similar, but a little different. So there are studies that use this model instead, at which it may better capture the confounders between the levels. And then the structural assessment that we're using is rather new, and it has primarily been used with mental health. Now, Family Preservation Services has a therapist and a skills coach going into the home, so mental health is a piece of the work that Family Preservation Services is using with a family. But since it's a newer assessment, though it has shown validity and reliability, and we are using it within an area that it may not have yet been fully tested on. Proposed next steps. There's some further possibilities here. First, we want to continue to see research coming out that shows the efficacy of family preservation services. Since FPS is only 5 years old, this type of research needs to continue to be produced. Second, there is the possibility of taking this research that's going to be done through this proposal and clone the very methods onto other clearinghouses, such as the California Evidence-Based Clearinghouse, or other ones, such as what probation services use, which is blueprints. There is the potential to test for additional covariates, such as maybe gender differences, or at an agency level, adding in an agency level, or looking at the number of hours a provider was trained in evidence-based programs overall. And then finally, as we look at these clearinghouses and we delve into deeper looking at the theories and the models that they have, it is highly evident that some of these models and theories have research that is 10 years or older and nothing newer. So it may be a good recommendation for these evidence-based clearinghouses such as Title IV-E to create a process that starts to reduce the evidence-based program ratings, scientific ratings, when that model doesn't keep up with current research. Because as things change, there is a possibility that the model becomes stale or stagnant. I want to say thank you for taking the time to watch this video and this research proposal. I hope that you have a great day, and God bless.